First question is regarding the diagram of a neuromuscular junction and what are the different methods to check the neuromuscular junction blockade. Basically, after we give a non-depolarizing muscle relaxant like an atracurium, we develop intubating conditions favorable for the patient for us to pass an endotracheal tube. And whether the patient is completely relaxed or not is checked by us by methods like train of four. So what exactly is train of four and a TOF of four, which we have to reduce it to a TOF of zero before intubation, we will see in this session. So coming to the basics of the diagram of a neuromuscular junction, as you can see on the left hand side, this is the nerve ending and it is attaching it to the muscle. So whenever there is a nerve action potential, there is entry of calcium, which causes the release of acetylcholine, which is stored in the nerve endings. Now, this acetylcholine transverses the neuromuscular junction, goes on to the muscular part through the sodium channels, activates the muscle action potential, leading to muscle contraction. So basically, acetylcholine is the enzyme which is responsible for the continuity of the neuromuscular junction. And this enzyme here, which is the acetylcholine esterase, it breaks down the acetylcholine, leading to muscle relaxation. So these are the vesicles of acetylcholine where it is stored and released into the synaptic cleft for the motor end plate to get activated, for the contractile elements within the muscle fiber to get activated. Now, our muscle relaxant antagonism or neostigmine, it is an acetylcholine esterase inhibitor. It inhibits this enzyme, which ultimately helps our acetylcholine to reach to the other side of the membrane and effectively cause muscle contraction. So this is a basic diagram of a neuromuscular junction. Next is, what are the different methods of measuring the evoked muscle responses? Now, traditionally, we have been using several clinical tests which might prove unreliable as they are subjective and multifactorial to assess. So things like when the patient is coming out of anesthesia or the patient is out of muscle relaxation, things like eye opening, sticking out of the tongue, hand raising, obeying commands with response to motor activities like obeying the hands and the legs, the normal tidal volume, maximum inspiratory pressures which are being generated by the patient to take spontaneous breath, a sustained head lift of more than 5 seconds, leg lift of more than 5 seconds, a sustained good hand grip of more than 5 seconds. All these are indirect indicators that the patient is out of muscle relaxation. Also, you can check the gag reflexes by putting in a tongue depressor to test for the gag reflexes. So all these, along with visual assessment and tactile assessment, give you a fair idea whether the patient, at what level muscle relaxation is there in the patient. But nonetheless, these are not objective parameters of measuring the patient, and hence tests like acceleromyography, mechanomyography, electromyography, kinemyography, phonomyography, and compressomyography. Basically, whatever stimulus you are giving, you are measuring the extent of muscle contractions in the patient. The most commonly used in clinical practice is the acceleromyography for the neuromuscular junction monitoring, also known as the train of four monitoring. So whenever you're using sound or mechanical displacements, you can see devices like phonomyography or compressomyography not used in clinical practice. So for us, mechanomyography was a basic test, which was a measurement of evoked muscle tension. The most commonly studied muscle is the adductor pollicis or the thumb. When the ulnar nerve is stimulated at the wrist, the adductor pollicis contracts and causes the thumb to move. Now, if the thumb is stabilized and fixed under a fixed amount of tension, also known as the preload, then the evoked responses can be measured as a change in this tension which develops at the thumb. And electromyography is the recording of a compound action potential that occurs during muscular contraction, whether voluntary or evoked. Now, which nerves or which areas of the body can be used for mechanomyography? That is adductor pollicis or ulnar nerve most commonly used, but other sites like hypothenar eminence or the first dorsal interossei muscles, they can also be used. Now, basically, evoked action potentials are a measurement of electrical changes that occur in muscle during stimulation, and it is assumed that these are equivalent to the muscle contractions. So, thus, mechanomyography was a basic science to check the evoked muscle tension. Building on it, with a similar principle, acceleromyography has been developed, where instead of measuring the force of contraction directly, what is measured is the acceleration of the contracting muscle. Now, as we know the Newton's second law of motion, that is force is equal to mass into acceleration, that is F is equal to m into A. So this acceleration, how it is measured, it is done by a piezoelectric ceramic wafer that is strapped to a thumb, or what we know as the TOF machine. And when the adductor pollicis is stimulated, the thumb will move and the attached transducer will produce a voltage which is proportional to its acceleration. Now the voltage then can be converted into an electrical signal and it is displayed as a twitch response. So for accurate measurement, the accelerating digit must be free to move. If the accelerating digit or the digit which is under examination, if there is no place for free movement or it is obstructed by the side table or some strap, then the reading will not be accurate. Also, all these tests need normothermia as a prerequisite for good results. Also, TOF monitors have to be calibrated before applying to each patient. You have to do a thorough calibration of the instrument, after which a supramaximal stimulus is given to check for the TOF. So supramaximal stimulation is basically the electrical stimulus that is 15 to 20% above that is necessary to produce the contraction of all the muscle fibers supplied to a nerve. Since such calibration is unpleasant for the patient, it is performed after giving a loading dose of propofol. Imagine an awake patient and you are twitching the thumb of the patient. It will be unpleasant for the patient. So after the administration of an analgesia and a loading dose of anesthesia, prior to giving the muscle relaxant, you can do the calibration and do a baseline TOF measurement. The advantage of objective methods of assessing the degree of muscle relaxation is the lack of influence on the result of simultaneously administered intravenous anesthetics, opioids, and inhaled anesthesia agents. So as you can see in this diagram, what all muscle groups are blocked after the administration of a neuromuscular blocking agent. We are basically involved to block the diaphragm, after which the laryngeal muscles and corrugator supercilii muscles are blocked. Then the adductor pollicis muscles are blocked, and lastly the pharyngeal masseter muscles and the tongue, that is the genioglossus muscles, are blocked. Now, why is there a hierarchy in this group of muscles to get blocked? Because some muscles receive a relatively higher blood supply and they are more resistant to neuromuscular blocking agent when compared to peripheral and pharyngeal muscles. So even if the patient may breathe or cough, even at TOF counts of 0, which is measured at the adductor pollicis, because the diaphragm is quick to get blocked and also it is that sensitive to come out also. So whenever the TOF ratio is 0.7 to 0.9, patients are predisposed to the risk of airway obstruction and aspiration. Now, why is TOF monitoring or neuromuscular junction monitoring is important? Because at any cost, we do not want any cases of residual paralysis post our general anesthesia. So what happens in residual paralysis of the patient? In about 30% of the patients, there is diplopia, swallowing difficulty, muscle weakness, airway obstruction, and delayed recovery. In 1 to 5% of the patients, there can be post-operative pulmonary complications, re-intubation, and significant hypoxia, which is another significant concern. And in less than 1% of patients, you might have to admit the patient in a critical care unit. So, in order to avoid these consequences of residual paralysis, proper monitoring of TOF count, giving muscle relaxants according to TOF counts, and reversing the patients according to the objective monitoring of the neuromuscular junction will help us to avoid these complications. So these are the phases of a non-depolarizing blockade post atracurium or vecurinium. So a train of 4 count or 4 or TOF ratio is 1 before just giving the neuromuscular blocking agent. When you administered a loading dose of atracurium, the TOF count gradually fades from 4 to 3 to 2 and 1. When the TOF count is 0, you can start intubation. The patient is completely relaxed. Intraoperatively, you can keep the TOF count. If you want a complete block, you can keep a TOF count of 0, which will give a post-tetanic count of 0 as well. Mind you, post-tetanic is a very painful stimulus, and it has to be done only when you are sure that the patient is in deep blockade. So just before induction and in the peri-extubation event, post-tetanic count is not of much use, but TOF count can be monitored throughout the procedure. Now, if you want a deep block, you can go for a PTC of 1, but TOF count should be 0. And most procedures require moderate to deep block only. There are certain conditions where intraoperative neuromonitoring is required, where you want the TOF count to be 3 or 2 so that you can do the intraoperative neuromonitoring, especially in cases of motor evoked potential monitoring done in intra neurosurgery, spine surgery, complex scoliosis surgeries. So in these cases, TOF monitoring is mandatory. Now, at the time of emergence and extubation, TOF ratio of more than 0.9 is considered to be good acceptable recovery and patient can be extubated. And there is minimal block within a TOF ratio of 0.4 to 0.9 and a shallow block with a TOF ratio of less than 0.4. So for good recovery, acceptable recovery and extubation, TOF ratio of more than 0.9 is mandatory. So as you can see this chart, the depth of block, if it has to be complete, the PTC count has to be 0. For the deep block, PTC count can be 1, but the TOF count has to be 0. For a moderate block, a TOF count has to be between 1 to 3. A shallow block TOF count is 4 and a train of 4 ratio of less than 0.4 is acceptable. For a minimal block, TOF 4 has to be there with a train of 4 ratio between 0.4 to 0.9, and acceptable recovery is only when the train of 4 ratio is more than 0.9. So as you can see, what percentage of receptors are blocked when you are interpreting the train of 4 response. So if there are 0 by 4 train of 4, that is there is 100% block, and if there is 3 by 4 response, around 65 to 75% of the receptors are blocked in that case. So what all to monitor at different stages of surgery? So during induction of anesthesia and tracheal intubation, the muscles of the larynx and jaw must be paralyzed, as well as the diaphragm must be completely paralyzed in order to ensure a smooth intubation. The orbicularis oculi is probably the ideal muscle to monitor at this time, as it is more similar to the central muscle. The onset of block will be similar to the laryngeal muscles and diaphragm. A single twitch or TOF stimulation is the most valuable stimulation pattern at induction, and according to your TOF, you can titrate the NDMR dosage. A single twitch stimulation will allow the maximal stimulation level to be obtained. The disappearance of the TOF will correspond to optimal intubating conditions. So then in the maintenance phase, as the diaphragm is relatively resistant to the neuromuscular block, A more sensitive peripheral muscle, such as the adductor pollicis, may not adequately reflect the degree of block required at this stage of anesthesia. A central muscle which is resistant to neuromuscular block, for example, the orbicularis oculi, will reflect the diaphragm more closely and it should be monitored. So intraoperatively, even if the patient is draped, you can just see the twitching of the orbicularis oculi. And in the profound neuromuscular block phase, PTC and TOF monitoring are useful. So coming to the reversal and recovery of the patient, before administering a neuromuscular antagonist, that is neostigmine, the TOF count should be at least 3. At this time, monitoring a peripheral muscle such as the adductor pollicis, it is the best option. The respiratory muscles are likely to have recovered to a greater degree, and monitoring a peripheral muscle requires a larger margin of safety. So different TOF counts are there during different phases of surgery, and accordingly you can plan your reversal and extubation as well.